In 1995, while most of the world was waiting for a dial-up modem to load a single web page, artificial intelligence was actually already quietly diagnosing gynecological conditions.
Yeah, it's honestly wild to think about.
Right. I mean, a neural network was literally receiving FDA approval to scan human cells back then. But nearly 30 years later, when it comes to women's intimate health and severe menopausal symptoms, modern medicine is, often still relying on this sort of spray and pray approach.
It really is. You grab a generic treatment, you hope it fits your unique biology, and, well, you just deal with the consequences if it doesn't.
Exactly. And when we step into the world of new medical technologies, that off-the-rack approach isn't just uncomfortable for you, it can actually cause real lasting harm.
Oh, absolutely. It represents a massive medical gray area. We are looking at a space where generic, factory preset technology is just colliding with incredibly complex, highly individualized human tissue.
Welcome to another deep dive. Today, we are exploring the fascinating and honestly quite complex intersection of women's intimate health, medical lasers, and the absolute frontier of artificial
That's
intelligence.
a huge topic.
It is. Specifically, we are diving into our sources to answer a highly futuristic but incredibly pressing medical question. Can AI enhance vaginal laser treatment customization?
And that is a question that requires us to bridge, biology, laser physics, and computer science all at once.
Right. So to get to the bottom of this, we have a stack of incredibly detailed sources in front of us today. We're looking at clinical guidelines from the National Institute for Health and Care Excellence, that's NICE, and the British Menopause Society.
Hmm.
We're also pulling from scientific impact papers from the Royal College of Obstetricians and Gynecologists, along with some really interesting clinical briefings from the Women's Health Clinic.
It is a really robust stack of literature. I mean, it ranges from the very immediate physical realities of menopausal symptoms all the way to the bleeding edge of machine learning algorithms.
Yeah, and our mission today is to cut through both the dense medical jargon and that shiny tech hype. We're going to explore the physical realities of menopausal health, why lasers are being used in the first place, and how AI might actually transform these treatments from a risky, one-size-fits-all gamble into hyper-personalized care. Okay, let's unpack this.
So before we can even begin to understand how artificial intelligence and lasers work together, we really have to ground ourselves in the human biological problem they're actually trying to solve.
Right, the root cause.
Exactly. We have to understand genitourinary syndrome of menopause, or GSM.
And most people listening probably know the basics of menopause, hot flashes, hormone drops. But GSM encompasses a very specific and severe set of structural changes, doesn't it?
It does. GSM is basically the medical umbrella term for a group of symptoms caused by a systemic lack of estrogen in the pelvic region.
Okay.
When estrogen levels plummet, the physical changes are profound. We're looking at severe vaginal dryness, intense pain during sexual intercourse, which is medically known as dyspareunia, and tissue friability.
Friability, like fragile.
Exactly. Friability means the tissues lose their elasticity and become so fragile they easily tear or bleed under just normal friction.
Wow. And the sources mention this goes far beyond sexual health, though. It affects the entire urological system for you.
Yeah, because the tissues of the vagina and the lower urinary tract actually share the same embryological origin, so
Yeah.
they both rely heavily on estrogen.
Oh, I didn't realize that.
Yeah, so GSM also includes urological symptoms. We're talking extreme urinary frequency, sudden urgency, recurrent urinary tract infections, and even hematuria, which is blood in the urine.
That sounds incredibly painful.
It is. It severely impacts your day-to-day quality of life, psychosexual health, and just overall well-being.
So let's talk about how we fix this structurally. I like to think of estrogen as sort of like the foreman at a construction site or like a sprinkler in a
I
garden.
like the garden analogy.
Yeah, right. Like when the sprinkler is on, the garden is hydrated and healthy. Or going back to the foreman, when the foreman is there, the workers are busy laying down bricks, building collagen, keeping the building structurally sound. But during menopause, the foreman leaves the site, the workers stop building, the maintenance stops, and the structural integrity of the tissue just crumbles. To fix the building, the British Menopause Society says you need to bring the foreman back.
That is precisely the current gold standard of care: low-dose vaginal estrogen.
Meaning it's applied directly to the tissue, right, rather than a pill you swallow that circulates through your entire bloodstream.
Right, exactly. Vaginally delivered estrogen is incredibly effective because it acts locally. It actively restores cell maturation.
Okay.
It signals the body to improve blood flow to those specific tissues. It also promotes healthy bacterial flora, specifically lactobacilli.
Which is good bacteria.
Yes, those bacteria produce lactic acid, which brings the vaginal pH back down to a healthy acidic level below 5. And that creates an environment that fights off infections.
So it essentially puts the foreman back on site. But here's the crucial question that really arises in the sources. What if you are strictly forbidden from bringing that foreman back?
Right, the contraindications.
Yeah, like if you are one of the millions of women diagnosed with hormone receptor-positive breast cancer, and you're taking aromatase inhibitors, you can't use estrogen, right?
No, you can't. Aromatase inhibitors are drugs designed to completely starve the body of estrogen to prevent the breast cancer from returning.
Wow.
So for these patients, introducing even localized vaginal estrogen is often deemed an unacceptable risk by their oncologists. Or, frankly, the patients themselves simply refuse hormonal therapies out of an abundance of caution.
Understandably so.
Yeah.
But if estrogen is completely out of the question because of cancer risks, how do you rebuild that tissue architecture without hormones? The sources mention moisturizers, but that just seems like putting a tarp over a crumbling building.
That's a very accurate way to put it. Lubricants and moisturizers provide temporary symptomatic relief. They reduce friction during intercourse. But as the guidelines note, they do not reverse the underlying architectural changes of the tissue. They don't stimulate collagen production or restore blood flow. They just, temporarily hydrate the surface layer.
So this requires a massive shift in how medicine approaches the problem. If you can't use biochemistry, you have to use biophysics.
Exactly.
Doctors started looking at how dermatologists use lasers to remodel skin on the face, to erase wrinkles and build collagen. And they asked, could this work internally?
And that transition to the pelvic floor is exactly where the controversy begins. The primary tools here are the CO2 microablative laser-like, the Monalisa Touch, and the Erbium YAG laser.
Wait, but vaporizing tissue inside the body, that sounds like it would cause massive scarring, not healing. How is firing a high-powered laser into fragile, friable tissue a medical solution?
Well, it relies on a biological process called neocollagenesis, which is triggered by controlled injury.
Controlled injury. Okay.
Yeah, the laser energy is highly attracted to the residual water molecules within the connective tissue. When the laser hits that water, it instantly heats up.
I see.
In the case of the CO2 laser, it vaporizes the very top damaged layer of the epithelium, while the heat diffuses deeper down into the tissue base.
So you are intentionally causing a microscopic burn.
Basically, yes.
Yeah.
You are causing localized thermal stress. This mild swelling and stress acts as an alarm bell for the body's fibroblasts.
And fibroblasts are what?
They are the actual workers at your construction site. The heat tricks them into thinking there has been a trauma, so they rush to the area and start rapidly producing new collagen and elastin fibers.
Oh, wow.
It also triggers neovascularization, which is the formation of new blood vessels. So you are essentially hijacking the body's natural wound-healing cascade to rejuvenate the tissue without relying on estrogen.
Okay, looking at the mechanics, the Monalisa Touch uses something called a D-pulse. Why does the shape of the laser pulse matter so much?
The D-pulse is fascinating. It delivers a massive initial spike of energy to instantly ablate or vaporize that top surface layer without burning it.
Just a quick zap.
Right. Then the pulse drops to a lower energy level and holds it there for a longer duration.
Okay.
That long tail of lower energy allows the heat to gently seep deep into the lamina propria, the connective tissue, to stimulate those fibroblasts without carbonizing the surface.
In theory, that sounds like a brilliant, elegant solution for breast cancer survivors. But reading through the documentation from the regulatory bodies, they are forcefully pumping the brakes on this entire procedure.
Oh, absolutely. Yeah. The US FDA issued a very stark warning against using energy-based devices for what they call vaginal rejuvenation.
Yeah, the guidelines were pretty strict.
And the NICE guidelines in the UK, specifically IPG 696 and IPG 697, state that the evidence for the long-term safety and efficacy of these lasers is simply inadequate.
NICE actually requires special arrangements for clinical governance and audit. What does that actually mean for a patient walking into a clinic?
It means the procedure should not be considered standard routine care.
Got it.
Any clinician offering this must have strict protocols in place. They must obtain explicit informed consent, ensuring you understand the uncertainties.
Because it's still so new.
Right. Furthermore, they are obligated to track and audit your specific outcomes to help build the missing evidence base. It's a therapy meant for research settings or cases where literally every other conservative measure has entirely failed.
Let's dig into that missing evidence base. Because the trial data is kind of all over the map. You have observational studies showing women getting massive symptom relief, feeling like they have their lives back.
Hmm.
But then you look at the sham-controlled trials from the NICE guidelines, and the narrative totally flips.
Yeah, that's where it gets complicated. In a sham-controlled trial, one group of women receives the actual laser treatment, while the other group undergoes a fake procedure where the probe is inserted, but no laser energy is fired.
A placebo laser.
Exactly. And some of these larger, rigorous trials showed absolutely no statistically significant difference in symptom relief between the real laser and the fake one at the 12-month mark.
But wait, how does a fake laser cure severe vaginal atrophy? That doesn't make any mechanical sense.
Well, the fake laser doesn't cure the atrophy. The structural dryness and friability remain.
Okay.
However, the placebo effect regarding the perception of pelvic pain is historically very strong. The psychological impact of receiving care, the expectation of healing, can significantly alter how the brain processes pain signals during intercourse, even if the tissue itself hasn't changed at a cellular level.
Wow, the brain is powerful. But while the placebo effect might be harmless, the MUDE database, which tracks adverse events, shows that the real laser isn't always harmless. It reports rare but severe complications.
Yes, very severe.
We are talking about vaginal fibrosis, which is rigid, permanent scar tissue, and chronic, long-term pain.
And the clinical papers analyzing these adverse events largely attribute the severe burns and fibrosis to operator error or inappropriate excessive energy settings.
This brings me to an analogy. The current state of vaginal lasers feels like using a microwave on a generic factory setting.
Okay, I'm listening.
You put your food in and hit the defrost button. Sometimes it perfectly thaws your meal, but other times, depending on the exact weight, density, and water content of the food, it leaves the center freezing cold or it completely burns and hardens the edges.
That's a great way to visualize it.
Right, because if every woman's vaginal tissue has a completely different level of atrophy, hydration, and thickness, isn't the lack of consistent results simply a problem of the laser, the microwave, not being customized to your unique tissue density?
That is the precise engineering flaw we are currently facing. A clinician is relying on visual inspection and generalized protocols to make an educated guess on the energy settings, the penetration depth, and the pulse duration.
Which is just a guess at the end of the day.
Right. If your tissue happens to be thinner or has less water content than the protocol expects, that standard burst of thermal energy will cause a severe burn rather than gentle fibroblast stimulation.
And solving that generic microwave problem is really the core focus of our deep dive today. This is where artificial intelligence offers a radically different approach to how we deliver this energy.
What's fascinating here is AI transitions this from a static, predetermined procedure into a dynamic, fluid conversation between the machine and the human body.
A conversation.
Yes, according to clinical briefings from the Women's Health Clinic, AI-driven platforms are being developed to analyze tissue data in real time while the laser is actively firing.
I really need to understand the mechanics of that. How does a machine talk to human tissue mid-procedure?
Primarily through measuring impedance, alongside real-time optical imaging and temperature sensors.
Impedance, like electrical resistance.
Exactly. Human tissue conducts tiny, safe electrical currents. Because water conducts electricity very well, highly hydrated, healthy tissue has low electrical resistance, low impedance.
Okay, that makes sense.
Conversely, severely atrophied, dry tissue has very high impedance.
So the laser probe is sending out electrical pulses, reading the resistance, and feeding that data into the AI.
Thousands of times a second. The AI system continuously monitors that impedance feedback. It knows exactly how much water is present in the specific millimeter of tissue it is targeting.
So if the AI senses the tissue is incredibly dry and the temperature is spiking too fast, risking that permanent scar tissue, the fibrosis we talked about, how does it react?
It adjusts the laser parameters on the fly. Millisecond by millisecond, the algorithm can lower the energy output, shorten the pulse duration, or change the depth of penetration.
That is incredible.
It really is. It stops the heat before it crosses the threshold from controlled stimulation into destructive scarring. Furthermore, by utilizing machine learning models trained on vast data sets of previous procedures, the AI could theoretically predict your individual tissue response before the clinician even steps on the pedal.
It essentially turns the generic microwave into a smart oven that constantly measures the internal temperature of the food and adjusts the heat so every single molecule is cooked perfectly. That sounds like a monumental leap forward for patient safety. But the sources, particularly the MHRA and FDA documents, contain a heavy caveat.
Oh, a very heavy caveat. We are still looking at early prototypes and theoretical frameworks for this level of dynamic integration.
So it's not quite ready for prime time.
Not entirely. The regulators stress that robust, massive clinical studies are desperately needed to prove this real-time adjustment actually improves long-term outcomes.
Huh.
And crucially, they mandate that AI must support, not replace, the clinical judgment of the practitioner.
Right.
The AI is a highly advanced navigation system, but the doctor is still flying the plane.
That raises a critical point. Real-time laser adjustment driven by machine learning sounds like absolute science fiction. To understand if this is actually feasible in a clinical setting right now, we need to look at AI's current track record in the broader field of gynecology. Is this technology actually ready to fly the plane?
Well, we often view AI in medicine as a brand new phenomenon, but the RCOG Scientific Impact paper highlights a remarkable piece of history. One of the earliest AI-enabled medical devices ever approved by the FDA was actually in gynecology, way back in 1995.
1995. That is the era of floppy disks and dial-up internet. What was an AI possibly doing in a gynecology clinic back then?
It was a system called PapNet. It utilized neural networks to analyze cervical smears.
Really?
Yeah, a single smear slide can contain up to 200,000 cells, and a human pathologist had to scan through all of them, looking for a handful of precancerous abnormalities.
That sounds exhausting.
It was. So PapNet's algorithm scanned the slide, identified the cells with the most abnormal morphological criteria like enlarged nuclei, and flagged the top 128 most suspicious cells for the human pathologist to review on a monitor.
So it basically found the needle in the haystack and handed it to the doctor. That perfectly illustrates that assistant dynamic.
Exactly. And today, the applications in gynecology oncology are just staggering. Researchers are utilizing tools like random forests and deep convolutional neural networks.
Okay, let's break those down. Because random forests sounds like a Bob Ross painting, not advanced computer science. How does that work?
It is a brilliant statistical method for handling complex medical data. Imagine you need to diagnose a pelvic mass on an ultrasound. A single decision tree might ask, is the mass larger than 5 centimeters? If yes, go left.
Okay.
Is the blood flow abnormal? If yes, go right. But a single decision tree is prone to errors. A random forest algorithm creates thousands of these decision trees, each looking at slightly different randomized subsets of the patient's data, and then has all of those trees vote on the final diagnosis.
Oh, wow.
Yeah, the majority rules, drastically increasing accuracy.
And what about the deep convolutional neural networks?
Those are specifically designed for image analysis. They are currently being used to analyze whole slide imaging of tumor tissues to predict survival rates, or to look at MRI scans to predict whether cervical cancer has spread to the lymph nodes.
That's wild.
It is. They're often spotting pixel-level patterns that human eyes simply cannot perceive.
But wait, if the AI is this advanced, if it can scan hundreds of thousands of cells, vote on complex diagnoses, and see patterns invisible to humans, why isn't it already standard practice in every single clinic dynamically adjusting our lasers?
Well, there's a big jump between those two things.
Here's my analogy for this. AI in medicine right now is like an airline pilot who has spent 10,000 hours mastering the world's most advanced flight simulator. They know every textbook emergency procedure flawlessly, but they have never actually flown a real plane filled with passengers into O'Hare Airport during a Thanksgiving blizzard. The simulator is a static environment, but the blizzard is a dynamic one.
That is spot on. Moving from analyzing a static, digitized image of a cell to firing a live laser into living, breathing, bleeding human tissue introduces variables that algorithms really struggle to anticipate.
Which brings us to the roadblocks.
Yes, this leads us directly to the stark limitations and roadblocks currently holding this real-time AI integration back.
Let's look at the specific roadblocks highlighted in the RCOG paper.
The first major technical hurdle in developing these models is a phenomenon known as overfitting.
Overfitting. How does that impact the algorithm?
Overfitting occurs when an AI model learns the data it was trained on almost too well, including all the background noise and specific quirks of that dataset.
Okay, give me an example.
Imagine training an AI to recognize dogs, but you only feed it pictures of golden retrievers taken outdoors on sunny days. The AI becomes flawless at identifying golden retrievers in the sun.
Right.
But if you show it a bulldog in the snow, it fails completely because it thinks sunny grass is part of what makes a dog a dog.
Oh, I see. So it memorized the specific answers to the practice test, but it failed the general concepts on the actual exam.
Exactly. In medicine, this happens when an AI is trained on data from one specific, highly funded research hospital with a very specific demographic of patients.
Yeah.
The AI looks incredibly accurate in testing, but when you deploy that same AI algorithm to a rural clinic with different patient demographics, different hydration levels in the population, or even a slightly older laser machine, the AI's predictive accuracy just collapses.
Which naturally brings up the issue of data inclusivity mentioned in the
Oh,
sources.
absolutely. The RCOG strongly points out that AI research is often driven by whatever massive data sets happen to be conveniently available to the computer scientists, rather than data compiled specifically to address diverse patient priorities.
Right, whatever's easiest to get.
Exactly. And if the data used to train vaginal laser AI isn't inclusive of all races, ethnicities, ages, and socioeconomic backgrounds, the AI will learn those blind spots.
It's terrifying.
It is. It might recommend inappropriate laser energy settings for a patient whose tissue density differs from the narrow demographic the machine was trained on.
So it basically inherits our historical blind spots.
Now,
And then the sources detail another massive transparency issue, which is the black box problem.
this raises an important question regarding clinical trust. Many advanced AI models, particularly deep neural networks, function as black boxes.
Meaning we can't see inside them.
Right. We know the complex patient data that goes into the system, and we see the laser adjustment prediction that comes out. But the incredibly dense mathematical pathway the AI took across millions of parameters to reach that specific conclusion is functionally invisible. It's
Wow.
invisible even to the software developers who built it.
So it gives you the answer, but it literally cannot show its work.
Precisely. And in medical practice, explainability is everything. If a clinician is watching an AI suddenly spike the laser energy during a procedure, and the clinician doesn't understand why the algorithm made that decision, how could they confidently support that action or intervene to stop it?
Which leads directly to the ultimate nightmare scenario for any hospital board or medical director. Liability.
The legal gray area.
Yeah, if an AI is dynamically reading impedance, and it autonomously adjusts a vaginal laser during a procedure, and it makes a miscalculation that causes a third-degree vaginal burn or permanent fibrosis, who is legally responsible?
That is the million-dollar question. Is it the clinician who is holding the probe but trusting the screen? Is it the hospital administrators who purchased and approved the software? Or is it the software developer who coded the algorithm 5 years ago?
It's a mess.
It really is. The legal and regulatory frameworks required to handle semi-autonomous AI in interventional physical medicine simply do not exist yet.
So what does this all mean for you, the listener, right now? Let's bring all these threads together.
I think we are sitting right in the middle of a major transitional phase in gynecological medicine.
We really are. We've seen that if you are suffering from the severe realities of genitourinary syndrome of menopause, especially if you are someone who absolutely cannot use the gold standard estrogen treatments due to cancer risks, vaginal lasers offer a very real biophysical glimmer of hope.
They do. They offer a way to rebuild tissue architecture by stimulating your body's own fibroblasts.
But, as NICE and the FDA have made explicitly clear, this treatment is currently hampered by a lack of personalization, deeply mixed trial data, and the very real risk of generic settings causing burns and fibrosis.
And that's where the tech comes in. Artificial intelligence holds the incredible scientifically plausible promise of solving this exact engineering flaw.
By reading electrical impedance and tissue feedback in real time.
Right, it could transform these lasers from blunt generic instruments into hyper-customized, dynamically safe therapies.
But until the massive roadblocks of overfitting, non-inclusive training data, the black box mystery, and legal liability are cleared through robust long-term clinical trials, you should view these AI-enhanced treatments with a healthy dose of caution.
Definitely.
If you do explore them, you need to ensure they are only performed in highly regulated clinical settings, specifically under those special arrangements for audit and safety monitoring mandated by NANIS.
Moving forward, the safest, most effective care will require a collaborative partnership. It will require you, the patient, working alongside a highly trained human clinician, utilizing the technology strictly as a supportive assistant.
Which leaves us with a final thought to ponder as we wrap up this deep dive. As artificial intelligence becomes increasingly capable of customizing our medical treatments down to the microscopic cellular level, will the empathy, the intuition, and the nuanced understanding of human-to-human medical care become viewed as a luxury add-on? Or will it remain the essential core of true healing?
Ultimately, it is a question of whether we want a highly efficient mechanic for our bodies or a comprehensive healer for our lives.
Think back to the flight simulator. The AI might know every emergency procedure in the manual, ensuring the flight path is theoretically perfect. But only a human pilot can look back into the cabin, see the fear on the passengers' faces, and know exactly how to reassure them through the turbulence. Keep questioning the technology and keep advocating for your own deeply personal care. We'll catch you on the next deep dive.